to the American Indian and Alaska Native Behavioral Health webinar series. My name is Jenny Richards, and today we're really excited to welcome David Welch to speak on the Addiction Gateway Complex Developmental Trauma in Children. This training series is brought to you by the National American Indian and Alaska Native Addictions Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which include 10 regional centers and a network coordinating office. To learn more about the ATTC network, please visit our website. Coming up in June, we'll have a session on recovery-oriented systems of care led by our director, Dr. Anhelena Shinstad, Sean Baer, and myself. For our Essential Substance Abuse Skills webinar series on May 18th, Lenny Hayes will present clinical evaluation and treatment planning. We hope you'll be able to join us for future webinars as they come up. Our center is NADAC certified and is an ADAC certified educational provider, and we'd be happy to provide you with CEs or an extra $15 fee. The request form can be found available for downloading in the Files pod, which is in the lower left-hand part of the webinar screen, and will also be sent to you in a follow-up email for everyone that's attending today. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. And we thank you in advance for helping us to improve our programs through those evaluations. You'll be muted for the duration of this webinar, so please use the Q&A pod to share your questions and comments, and we will address the questions at appropriate points during the presentation. So if you have questions for the speaker in particular, just type them in the Q&A box, and I'll ask David when we hit a good point to break. If you prefer, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outwards. To return to the regular view, click the button again. Did somebody just say? Okay, sorry. We'd also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation in the number of CEUs you receive. The opinions expressed in this presentation are those of the presenter and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. Today's webinar is presented by David Welch. David is currently an affiliate faculty member of the Human Services Program at Metropolitan State University of Denver. David earned a Master's of Arts in Counseling and a postgraduate certificate in Counseling Military Families at Regis University and is currently pursuing a PhD in Counseling Education and Supervision at Regent University. During his postgraduate work, David received extensive training in addictions, trauma, post-traumatic stress, and resiliency building, working exclusively with combat veterans. David received his training in trauma-focused cognitive behavioral therapy at the Indian Country Child Trauma Center in Oklahoma City, Oklahoma. David has provided lectures on counseling combat veterans and counseling members of the American Indian community at institutions throughout Colorado, as well as at professional conferences nationally. He has spent the last 2 years on a federally funded research grant testing trauma-informed, evidence-based practices in Indian child welfare. He's now working with the Griffin Center for Children to expand the historic multi-generational trauma model to all historically oppressed cultures in the CPS system. Thank you so much for joining us, David. And I'm going to pass you over to things at this time. So hold on, I'll Ready for you, David. Hold on just a moment. It seems like we've lost David's audio, so hold on just a second.
All right. So, just basically want to look at the impact of childhood trauma on addiction. When we look at this from a historic trauma perspective, especially with the American Indian population, we're going to find that there's a lot of ties in. Those of you who've been in the field for a while, some of this may be review, especially with this community. But the goal is to actually look at not ways of excusing the bad behavior for some of our clients, but what tools can we use to help them understand what shaped where they're at in their addiction, and more importantly, what things and what changes do they need to make in their recovery to get to a healthier place. So the first thing I want to do is kind of the statistical look. And this is just to really kind of stress what the battle looks like. I think a lot of us, when we're in the trenches, we see it on a one-on-one level, but I think from a national scope, it's impressive, simply because based on the 2010 census, which was the first to allow people to choose more than one race, so we have 5.2 million American Indian and Alaska Natives identified, which is a total of 1.7% of the population. But because we allowed to have that multiracial identification, 2.3 million people were identified and added, I think, as a result, instead of back when you had to choose one or the other. In our population right now nationally, we have a 45% average unemployment rate. I don't have the differentiation between what that looks like from urban natives versus reservation natives. Just know that that's the current number that they have out there. The big piece of this is 30% of our population lives in poverty versus 6% of the culture nationally, and that does play into some of the stuff that we have going on. When we look at the mortality rate, deaths per 100,000, and this is according to the CDC, 365.1. Our life expectancy is significantly lower than the dominant population. Unintentional injuries are our third leading cause of death. And the challenge we have is we don't even know if these are really good statistics, because 30% of our people aren't even identified as American Indian on their death certificates, because the coroner can't tell the difference. So if we look white, we're going to be called white. If we look Hispanic, they're going to tell us Hispanic. And so there may be significantly higher numbers that aren't being well tracked. So that's an area of research that if I were a coroner, I would probably want to look at. Suicide, and again, this is according to the CDC in 2009. Statistically, suicide is pretty high for 15 to 24 when we look at our population versus white males. It's almost a 2 to 1. In the females, when we look at 15 to 24, 13.4 versus 4. So that's almost a 3.5 to 1 ratio. And then with the older women, when they hit 25 to 44, 9.2 versus 8.1. So that's a little more than a one-on-one. The advantage we've got apparently as Native people, and probably because historically we have ingrained respect for elders, that once you reach elder status, we don't have the suicide rate that the dominant culture does. So that works to advantage if we make it that far. Mental health disparity, according to the American Psychiatric Association, and again, this is probably review for most of you. Our population 1.5 times more serious psychological distress than the general population. PTSD is more than twice the rate of the general population. As we know, use and abuse of drugs and alcohol started at younger ages and at higher rates. And then the suicide, of course, is the highest per capita than any other ethnic group. It is so significant that it is actually a test question, at least on the National Counseling Examination for the National Board of Counselors. I believe it is also on the national exam for social workers. So, for a number to be that significant that it's a test question on your board exams is something that we need to pay attention to. 1/3 of the Indian Health Service's patient care contacts were for mental health issues, and this is just on the reservation population. When we look at the statistics and it says 65% of American Indians live in urban environments in this country, then we have to assume that, if there's not an IHS contractor in that facility, again, this is a number of our population that's probably not being well tracked, and so this data could be skewed. The big thing is that our population is more likely to seek traditional healers than medical source, especially for mental health issues. And individuals that have that strong tribal spiritual orientation are statistically less likely to report a suicide attempt in their lifetime. So a big piece of keeping us healthy seems to be that connection to our tribal spiritual roots in addition to everything else we have going on. Crime rates, pretty significant. When we look at the crime rates, it's going to affect a lot of the mental health issues that we see. We're more likely to experience violent crime 2 times than the resident population. So about 1/3 of our victims of violence are between 18 and 24. That is the highest per capita for any ethnic group, which basically comes up to 1 violent crime for every 4 people in this age group, and many of which we'll be working with in this role. And then intimate partner violence, 39% of our women experience intimate partner violence, and when the studies were done at the Department of Justice, 70% of the violent victimizations were committed by somebody of a different race. So this isn't even American Indian or Alaska Natives abusing one another in these intimate partner violence relationships. This is people who sought refuge outside of that. Education, our education statistics nationally are still significantly lower than the dominant culture. 69% versus 83% average freshman graduation rate is pretty significant. I know here in Denver it was actually even worse for a while. There was a period about 10 years ago where we had almost a 75% dropout rate. Higher education statistics, and this is one of the reasons I believe training like this is so significant, and this is one of the reasons that we need to encourage our bachelor's level providers, if you've got any addiction counselors, whatever, to go ahead and get their master's degree and get that, because that number, the 0.125% of American Indians that have a graduate or professional degree, there's just not enough of us to do the volume of work in our community that's there. And so, this is one of the people we need to be really aggressive in training non-native clinicians on how to work with our population, especially in the addictions field, give them that understanding of what I'm going to talk about now as far as historic trauma and then also developmental trauma is concerned. So the statistics, as most of us probably already know, combined historic and multi-generational trauma plays heavily into this. If we look at the history of genocidal warfare against our people, this is pretty significant. For most Native people, when we went to war with somebody, it was not a war of attrition. You could not prove yourself, if you had warrior cultures, you couldn't prove yourself as a warrior unless you had a worthy adversary. And so, the goal was to prove your power over the enemy, but not wipe the enemy out. So when the Europeans started coming over, their model of warfare was vastly different. And I think from a cultural and spiritual standpoint, just the way warfare was done creates a significant wound on the warrior and the culture in and of itself, because this was just unheard of, to dismiss a culture's humanity based on the idea of manifest destiny. Then we've got a series of laws that limited our rights. There were some states, some cities, some towns that had laws to where if an American Indian was caught with a bottle of alcohol, they could spend up to a month in jail, whereas if they spent, they were just caught drunk and disorderly, they only spent the night. And so this creates a culture of power drinking. Plus, we got to look at our limited rights. The Citizenship Act of 1924, the fact that our people weren't included in the Civil Rights Act of 1964, and the American Indian Civil Rights Act had to be passed in 68. Our religious freedoms weren't guaranteed by the First Amendment, so we had to have the American Indian Religious Freedoms Act. All of this is going to affect the culture and create kind of that sense of historic trauma, that sense of historic loss, and a big piece of that is going to create this historic mistrust. And so for a lot of our clients that are involved in the child welfare system or they're involved with the justice system, there's going to be this huge resistance to dealing with anybody they believe that's attached to that. And as Native therapists, this is really huge because we don't want to be seen as part of the system. Even if we're employed by the system, we've got to do our best to make sure that, we understand this historic mistrust element. The government boarding schools, I think this is really significant in our culture simply because, if you've got children who were removed from their homes and placed in the care of people who aren't their parents, of people who don't love them, of people who aren't attached to them, then we're going to see generation after generation because of the boarding school of people with attachment issues, and that's going to create a whole nother level of trauma. Add the fact that most of those schools didn't necessarily have the most gentle of disciplinary styles, and so then we're adding physical trauma. Studies are showing and research has shown that a good number of our elders had actually been, sexually abused while they were in the boarding schools, and so we've got that level of trauma coming into it. And then the reservation and relocation conditions. For whatever reason, when Eisenhower came out with the relocation policy, thinking that if he moved all the Indians off the reservation and placed them in the city, the problems would go away, and they didn't. Because if you got a population that's been through multiple generations of trauma, if you have a population that's been through, challenges with employment, challenges with education, just changing their location will not fix that unless you address the underlying issues. So this is one of the reasons I believe that the historic trauma perspective in trauma-informed care is so important in the clients that we work with. So the boarding school legacy, when we look at the transgenerational effects just of the boarding schools, we're looking at the disruption of families, we're looking at the disruption of the community, we're looking at impaired emotional response because, if you're not around your mom and dad and you don't feel safe, you're not going to let those vulnerable feelings come out. You're going to learn to shut everything off and close everything down. Repetition of physical and sexual abuse, so we see this in our community, and a lot of times when we see this in the community, there's almost a direct link to one of our grandparents or great-grandparents that experienced a similar trauma in the boarding school. Confusion of parenting with punitive practices. This was really huge. I know my grandfather, when he was at Carlisle, he suffered significant amount of punishment just because he wouldn't speak English. And so his first year at Carlisle was horrific just because he insisted on speaking our language. Loss of knowledge, that loss of language, that loss of tradition, that's going to create a huge sense of loss and a huge sense of cultural trauma and historic trauma on any population that was affected by that boarding school system. And then the devaluing of Native identity. And I think this is really, really huge because, our culture and our people, that defines a lot of who we are. And if we cannot have a solid identity of our culture in a positive way, if we've been told by the boarding school that, our parents are stupid, our grandparents are backwards, you're dumb Indians, they're ugly Indians, uneducated savages, all these things were fed into them. And so a lot of the students left Carlisle with a very bad sense of self. And I think that's going to affect everything that came for the next several generations afterwards. So one of the things we look at is the impact of trauma on childhood development. This goes without saying that typically when we see a lot of trauma, we're going to see higher rates of unresolved mental health issues. A lot of that's going to come from those learned and inherited traits from untreated, traumatized parents. So this is where we're going to get that multi-generational PTSD. Alterations in brain development and physiology. This is really huge. And this is still theoretical research, but there's enough evidence that's starting to support this direction in what we now call complex developmental trauma. And that complex developmental trauma is going to be that idea of any trauma that you've experienced as a child will affect how your brain develops. And then when it affects how you're developed, then it's going to affect how you respond, how you act, how you process emotions, everything, even into adulthood. So one of the things that we have to look at, and I think this is the big piece of it, is I've worked with people in recovery, and I've seen enough recovery centers that they talk a lot about what addiction and what the addiction does to the brain as far as stimulating the pleasure centers and all of that. But I find for a lot of the people, nobody's told them about the brain they started with. So we're going to talk about the brain that the addicts started with. What led them to that compulsion to need to self-medicate? So first and foremost, Walter Reed Medical Center, they did studies about 8 years ago and they did brain scans pre and post deployment of infantrymen that were sent either to Afghanistan or Iraq. And what they found is that with a 1 year deployment of combat exposure, the amygdala had increased by 30 to 40%. Now, there's only so much space inside of our skull, so if something gets bigger, that means something's going to get compressed. But that hyperactive amygdala, that's that part of our brain, that's the fight or flight response. That's the internal danger alarm. If there's a lion in the room, what do I do? Do I run? Do I fight? Do I freeze? But this hyperactive amygdala, if we've got a child that, from the time they were infants and they're going through multiple traumas, they're going through multiple, issues that create this increasing level of anxiety, then they're making their amygdala larger and larger and larger, and their brain is always telling them, I'm in danger, I'm in danger, I'm in danger, I'm in danger. And for a lot of the people, and I'm sure you've done this in your practice for those of you that work with addicts, what was it like the first time you used? And this is why we often hear my brain went quiet, the anxiety went away, the fear went away, the chaos in my brain. I went from having 900 squirrels running around in my head to 5. And this is where that comes from, is that hyperactive amygdala is just constantly sending out this overstimulated brain signal. And we know when the amygdala is in charge, it is really hard for us to process anything else in the brain because of that amygdala. The amygdala override is so intense. The enlarged amygdala seems to compress and inhibit the hippocampus more than anything. And the hippocampus, that's where we store all of our emotional memories. So the first time we felt loved, it's there. The first time we felt terrified, it's there. The first time we go through any emotion, it is stored there forever. But it is also part of what holds our emotional regulation. It's part of what we use for attachment. It's connected to our ability to create serotonin and oxytocin. So our ability to, even chemically feel love and connection and joy and peace is affected by that. And so when we have unhealthy attachment, this is where we're going to find that increased risk for domestic violence, either as the offender or as the victim, because if I don't know what healthy relationships look like, if I don't have healthy attachment, I'm going to probably attach to other unhealthy people. And this is huge. And it seems that the emotional regulation piece of it is that, the part that gets compressed is the part that holds those good memories. It's the part that holds those healthy emotions. The part that doesn't get compressed and inhibited seems to be where anger and rage and fear are stored, which again will stimulate the amygdala and keep them in amygdala override. And then when we look at the diencephalon, that mid part of the brain, that's where our muscle memory is stored. So that exaggerated fight or flight response. This is the part of our brain that we train. When this happens, I do this. When this happens, I do that. So for example, if I'm out in my yard and I see something green and squiggly in the grass, and my amygdala goes snake, and then my hippocampus goes, with a fear response, the diencephalon is going to look and challenge that. And it may say snake, stomp it, or it may say garden hose, you can calm down. But if we don't have a lot of successes in our midbrain, if we've not trained our brain that, when this happens, I can do this and I'll have a good outcome. If the brain constantly has been fed negative information of no matter what I do, bad stuff continues to happen, then we're going to have that inability to recall past successes. We're going to have clients that honestly have no hope of it doesn't matter what I do, it never gets better. I've tried to quit drinking 5 times, already. I've been through 6 different rehabs. The only thing that seems to make sense to me is when I use meth. So that increased sense of hopelessness, and that's what adds to that suicide risk that we see in our population. And then the big piece is the inhibited prefrontal cortex. That decreased cognitive ability. If the amygdala is an override, and the lower part of my brain is always going, I'm in danger, I'm in danger, I'm in danger, and I'm in survival mode, then it's going to be really harder to think through things. Add the fact that when we go through this constant response and our brain is always in an agitated state, our cortisol levels will go up. And studies have been shown that when children especially have elevated cortisol levels, they cannot create new synaptic responses. So it's impossible for them to learn new things, which means it's going to be impossible for them to learn how to process emotions in different ways. So it's going to be impossible for them to learn new information. It's harder for them to get to a space where we can put data at them and they can comprehend and maintain it. So, this is where we're going to see our problems with school, Children that have a hard time in school. This is where we're going to find children that have a really, really hard time with emotional regulation, because, if the first time I felt disappointed when I was now 4 years old, and I've got so much cortisol that every time I'm disappointed after that, I'm not learning new ways to deal with it, I will always respond like a 4-year-old, because that's where that memory is stored. And with our people, especially when they're stuck in the addiction cycle, a lot of times this is why we'll see people who biologically may be 30, but emotionally they may be stuck 8, 9, 10, 12 years old. So that impact, this is where we have that increased likelihood of child protective services system or law enforcement involvement, statistically higher odds of losing parental rights. For American Indian families, especially if the addiction is involved in the dependency and negligence case, then they're looking at, a lot of parents are going to lose the rights of their kids unless they get appropriate level care. And this is where that trauma-informed piece is so, so important. A big part of the work I did at DIFRAC when I was on the grant was to help educate county attorneys and educate the judges and educate people in the system on, I can't make this get better in 6 to 8 weeks. That, the level of trauma work that I have to do on the kids and on the parents and on the family system as a whole, it might take 2 years to get them in a good place to where they can be effective, healthy parents for their kids. And the system doesn't like hearing that, because their response is, we're just making excuses for their bad behavior. The substandard incomplete education, this is one of the reasons I think our dropout rate is the way it is for a lot of our students. That cortisol level, it's making it harder for them to learn and remember, and therefore school sucks. I'm not as smart as the other kids. And it's not the fact that they lack the intelligence, it's the fact that, especially as young people, they've not had somebody teach them and help them how to calm down that I'm in danger signal in their brain. And so if they're always anxious, if they're always on alert, then yeah, it's going to be hard to learn new stuff, which leads to those limited life visions, those cognitive distortions. And we'll see this, everybody in my family's a drunk, everybody drinks. It'll always be this way. We'll always be poor. I'll never, life will never get better. And that leads to that loss of hope. And I think ultimately the soul wound. So one of the perspectives I have as a counselor when I work with my clients is I don't view addiction as the problem. I view the addiction as the symptom of the deeper soul wound. So this is a graph that I created when I'm talking to grad students and kind of explaining what we're dealing with in this multi-generational model and how that affects the brain development generation after generation after generation. So, in the red, we've got those patterns of neglect and emotional and physical abuse passed down from generation to generation. We've got untreated primary trauma, and post-traumatic stress, and during the Indian Wars and during the boarding school era. Anybody that went through those, that didn't get therapy, that didn't get some sort of mental health care or soul care, that amygdala is going to stay enlarged, that hippocampus is going to stay compressed, and if we make enough biological changes to our body, that is something that we can possibly pass on to our children. And so that means by the time it gets down to our current children, we're looking at generation after generation of people who have been through trauma after trauma after trauma after trauma, and then they experience their own trauma. The amygdala is going to keep getting bigger and bigger and bigger. So there's a good chance that from the day our kids right now come out of the womb, for severely affected families, the day they leave the womb, their brain is already going, I'm in danger, I'm in danger, I'm in danger. And that's where we find the greatest risk of addiction. Then add the secondary trauma, the stories of the Indian Wars, the story of the removal, the story of that forced acculturation, the emotional and physical abuse, the story of that. My father's justification was, you think I'm hard on you, you should have heard what they did to my father, Carlisle. So we got all that secondary trauma being passed down. And so we get this, pattern, not just of the actual traumas being passed on, but the stories, the patterns, and the behaviors. And so this is where we get, multiple generations of complex developmental trauma, multiple generations of actual trauma, and then multiple generations of post-traumatic stress, resulting in poverty and unemployment, substandard incomplete education, that limited life vision, that loss of hope, but more importantly, in the work that we do, a much higher risk of addiction, simply because the brain is so overwhelmed by all of this that the only way to escape it and the only way to quiet the chaos in the head is to self-medicate. So the mental health issues that we'll find with this, typically, addictions. And what I'm finding is that it's never just alcohol, it's never just meth. There's other things, there's other addictive behaviors that go to that. So I like to use the term a pair with a spare. And anybody that's gone to an AA meeting, even the buildings that have no smoking, look outside the AA building before and after the meeting. What's everybody probably doing? Smoking. The mental illness piece of it, that depression, that suicide rate, that's going to tie into this. But then the post-traumatic stress, I think, is the biggest piece of this, because we're looking at not just the primary and the secondary, but we're looking at a multi-generational model. And for the American Indian community, this is huge, simply because we've got so much going on as a group of people. But I'll even trace this back to like the hoarding issues and some of the obsessive disorders that we'll see. Especially a lot of times on the reservations. I remember working with some well-meaning people. We did a trip up to Pine Ridge, and one of these people from an upper middle-class white neighborhood were like, well, maybe they just feel better about themselves if they cleaned up their yards. They clearly didn't get what led to the hoarding in the particular yard that we drove by. Whereas I'm seeing, man, this is a person with a lot of pain. For me, this is one of the things that I really teach, especially the students who are in a counseling or social work program. The dual diagnosis with complex trauma means that as a therapist, we can't be just whatever our license or certification says we are. To be effective with the American Indian community, especially in the addictions world, we've got to be able to think like a licensed clinical social worker. We've got to be able to think like a marriage and family therapist. And then we've got to think like an LPC or a certified addiction counselor, whatever that credential is, where you're doing the one-on-one work. Simply because if you can't think this way, I think you're getting highly frustrated. And for those of you that are in the field, you probably already do this instinctively, but you'd be amazed when I'm talking to grad students, the fact that the idea that they have to make this kind of shift seems overwhelming, which would probably explain for, if we get a lot of people that are just, your department becomes a revolving door of interns and new hires and they don't stick around. I think this is the perspective that we're not providing them, especially if they're non-natives. Of, you're never just the counselor, you're never just the therapist, you're never just the social worker. At any given moment, we're always all three for whatever the case may be. So that, significant personal trauma, complex developmental trauma, multiple generations, end all and be all of counseling. But I have found that staying within the Bowen family systems theory has been the most helpful in my clinical practice, simply because it is the most flexible in providing good holistic care to work with the client, with the family, with the system, with the community. That integration of cultural elements and spirituality is acceptable in this realm. So I can do culturally responsive and trauma-informed care at the same time. So I'm going to kind of give a little perspective on Bowen family systems, simply because I think, especially for CACs and for LPCs, we don't get a lot of education in family systems work and family systems theory. And so we get taught motivational interviewing, we get taught some other skill sets, but we're never taught, from a theory perspective, how do we help this with the clients? So some things that are really unique. Bowen Family Systems, when Dr. Bowen created this model, and he currently has the Bowen Institute at Georgetown University, he was looking at, when we look at a family system, the idea is that the individual does not grow up in a vacuum. And so, what shapes us personally, what shapes us emotionally, what shapes us intellectually is not just the nuclear family of mom and dad, and maybe the influence of the grandparents, but then we're looking at the cultural influences, the community as a whole. And so for like Native people, especially with urban natives, is a good example. So we've got, the family structure of the parents and the grandparents. Then we have the extended family of, the Native community in Denver. And then we've got the influence of the dominant culture, whether you live in the white neighborhood, the Hispanic neighborhood, the black neighborhood, that's going to influence the family system. And all that ties into how we're shaped. And that's one of the reasons I like Bowen. But the big piece of this is in Bowen family systems, one of the challenges that Bowen found with most people that are struggling is that differentiation of self. People are too enmeshed in the family system, and they don't have that idea of self-identity. What's interesting for us as Native people is that for a lot of us in our native languages, there's no word for I or me. It doesn't exist. And so our identity is deeply rooted in that cultural whole. And so just looking at some of the names like Abenaki, the Dawn people, the Anawiya, which is the principal people, that's what the Cherokee call themselves, the Wallapai people, the Pine Trees, Meskwaki, Red Earth people, the Anishinaabe, the original people, the Nez, the Navajo, the people. And so when we have this cultural identity that's based on the whole, and we have this individual identity which is based on being a part of the whole, we're going to have a much harder time getting somebody to increase their sense of self-differentiation, especially if they're trying really hard to stay to that cultural spiritual balance. And so one of the goals we have as therapists is to help somebody find that middle ground of, as a member of the people, you need to have this joint identity and this joint piece of it. But for you to be in a healthy place, to get sober, to stay sober, to get your kids back, what do we need for you so that you can function in the dominant culture a little bit better? So it's kind of, how do I create an identity of myself while still being part of the collective? Does that make sense? I'm used to talking to classroom, so. So the nuclear family emotional process, this is really huge. The extensive partner conflict, that dysfunctional parents, emotional distance, the child impairment. When we look at the American Indian community, we fit this pattern because we've got generation after generation of traumatized, hippocampi. So, if I've got 9 brains in the family system and the hippocampus is not processing and regulating emotion well and not creating good emotional attachment, then I'm going to see an entire family system that is affected by this inability to have healthy emotional regulation, to have healthy emotional processing. This is where we're going to find, children who yell and hit because parents yell and hit because grandparents yelled and hit, and they're all living in the same home or they're all within close proximity to each other. That nuclear family transmission process, and this is huge. Typically what we'll see in non-native families is, we'll have the mom who's got this severe anxiety of not being adequate, and they'll project this onto the child of, Johnny hates me. And everything that's wrong with them is because their son hates them. And so, they'll constantly ask, Johnny, why do you hate me? Johnny, why do you hate me? Why? And at some point, Johnny's going to get annoyed hearing that and yell at mom, will you just stop asking? And that reinforces the belief of, see, Johnny hates me, something's wrong with me. When we look at the native community, this transmission process happens in a lot of different ways, not just in the family system of, mom drinks because they don't like me, dad hits me because I'm a bad kid, but then we're also looking at, the system piece of it, where the historic mistrust is involved of, as soon as CPS comes involved, they want to take away my children, they think I'm a bad parent, and this goes on because oddly enough, a good number of the families that I work with that are in child welfare, they themselves were in the foster care system, and so we're looking at multiple generations, especially in child welfare, of parents who were in the foster care system, and so the system has been failing them generation after generation after generation, which adds to that historic mistrust, that multi-generational trauma piece of it, which goes into the multi-generational transmission process because we see this heavily in our community, and it's just there. There's no denying that it exists. The emotional cutoff, I think this is really, really huge because those unresolved emotional issues of the family member, if I've got 9 people in the home and none of them know how to regulate their emotions, then they're going to do a couple of things. They're either going to physically escape and cut off their emotional contact with everybody else, which is why we'll see those addictions. I can't deal with these people, I'm going to go drink. Those escaping behaviors, whether it's cases of parents who decide when they relapse they just disappear, which we see. We've got a couple parents that have totally abandoned their kids for 6 months to a year at a time, and then when they finally decide to get sober again, they try to get back into the picture. But that physical cutoff is huge. And then the emotional piece of it, of whether we see that through neglect, whether we see that through conditioning, that stop crying piece of it. I know in my family this was huge, that the only emotions that we were allowed to show were anger, rage, and absolute rage. And so that emotional cutoff, don't show weakness, don't show, sadness, don't show fear. And so this expectation of I can't feel my emotions adds to the challenge, and I think helps create an unhealthy brain, which is more likely to be predispositioned to addiction. The societal emotional process, that levels of culturally appropriate stereotypes. And so, for example, how we as a society, show our emotions and express our emotions to the group. And if I've got somebody who has this image of themselves as the stoic Indian, and they combine this with their addiction, and we've got all these escaping behaviors that come with addiction, then what kind of behaviors are we going to see in this person? How is that going to project itself? Because in their head, they're trying to be a stoic Indian and live up to the stereotype, but they've created all these unhealthy behavior systems that make their life difficult as well as the lives of their family and especially their children. Treatment goals. This is one of the reasons I love Bowen Family Systems, because my treatment plans are relatively simple. Number one goal in Bowen Family Systems theory is reducing levels of anxiety, which helps me address addictions. It helps me address the post-traumatic stress. It helps me address the depression and even those OCD behaviors. So it's a really simple approach. And because it is this open, I can integrate techniques or styles or anything that my client needs to help them get to that healthier place. I'm not bound to a book that says I have to do A, B, C, and D, and that's all. Improving one's sense of self, and this is the big, that increased level of self-differentiation. So, if my identity is tied to the collective more than myself, what can I do to help find the balance between the two, to be in a comfortable place, to pursue my sobriety, because there's a good chance that somebody in my family system isn't sober yet. And if I want to stay stuck in that, then there's higher chance of being relapse, higher chance of bad behaviors continuing on to the next generation. So the counseling guidelines I have, and this is mostly when I'm talking to students. So for those of you who are already counselors and already doing this, please press on. But incorporate that model for prevention and intervention to address the historic trauma and the unresolved grief. I think this is the big piece of it, that the addiction is usually just a symptom. And yeah, we want to focus on sobriety. We want to give them the tools and the motivation and the desire to not use. But if we're only talking about the addiction and we're not trying to get to that unresolved soul wound, they're going to be at higher risk of relapse. And so, we've got to carefully walk that line of getting them sober, getting them healthy, and then getting them emotionally prepared to do the work to work through their trauma. And so this is not a quick process. This is one that takes a lot of time and goes from there. Consciously integrate, attend to the acculturation level and influence of oppression and experience the presenting issue. And we're going to find this, especially in the American Indian community, of a lot of people, they're in patterns and they don't even know where it started. So when I'm talking to my clients, especially in the Native community, and I explain to them that we have a generation of people that went through the Indian Wars, that went through the boarding schools, and went through the relocation era, and all the traumas that came with that, of being removed from home, losing culture, losing family. And then we got things like during the Eisenhower administration, the Indian Adoption Project. So governments were encouraged to take our children away. So all of this fear and all this anxiety, we have to address that. Because once they understand the system they came from, then we can talk that language of change, of what do we do to make this different for your children and your grandchildren. Consciously integrate the culture and the values into the counseling session. I think this is huge. For those of you that work on reservations where you're working with just one tribal population, it is definitely a lot easier. One of the challenges I have here in Denver is that the Denver Native community right now, I think statistically, have about 65 different tribes represented. And so we have the pan-native culture that I can pull from, but if they need something very tribally specific, then it's on me to help them find those resources to get what they need to hopefully get that, that cultural and spiritual connection with their people and with their traditions to help them get to a healthier place beyond psychotherapy. So some of the things that I use, again, if you're already in the field, and whatever you're doing, if it's working for you, I'm not telling you that it's wrong, but this is what I found that's been very, very helpful for me in my practice. First and foremost is motivational interviewing. I think everybody that works in addictions, we all get trained in this, and it's ultimately the language of change. But I think for our people especially, it's really helpful because it's a collaborative language. One of the challenges I had with the Child Protective Services system, I was sitting with clients, and they'd been sober about 6 months. But we're in a team meeting with the social workers and the county workers and all of that, and all the clients heard was, you do this, you do this, you do this, and it was all you. And then 3 months later we go for another meeting, and the whole county is complaining about the non-compliance. Well, you didn't do this, you didn't do that, you didn't do this, and I'm like, because you didn't word it as we. We're a collaborative culture, so what can we do to help you achieve this? And so we use that collaborative goal approach of what can we do to help you change, to help you get to a healthier place in your family. I think motivational interviewing, which I spelled wrong, is actually a really, really good tool. Narrative therapy, I like using narrative therapy simply because it ties into the oral tradition of most of our people. So letting them tell their story, letting them create their story. For some of the kids that I've worked with, letting them disassociate the story. So instead of saying, their first name or this is what happened to me, tell their story in the third person. One of my kids told his story based on him being a panther. And as Panther, what did Panther have to go through? That was so horrible that Panther was having a hard time in school. But that narrative therapy, I think, is really, really helpful. And again, for that oral tradition that our people have had for centuries, it's a lot easier. I know some counselors and some processes really try to push people to journal and write down their feelings or whatever. And it seems for a lot of Native people that is really a struggle. Trauma-focused cognitive behavior therapy. This was designed for children originally. It was actually designed for children who'd been sexually abused. But one of the things that I find is that even, and partly because of the training I went through at the University of Oklahoma at the Indian Country Child Trauma Center, was how to culturally adapt this for the Native community. But I'm finding this approach is actually really good for adults even, that I can integrate trauma-focused cognitive behavior therapy elements into the adult, again, to address that soul wound, to let them vocalize and voice what they experienced that was that soul wound. And more importantly, what it did to them, what they lost as a result of that, and then what do they need for healing? How do they create a sense of safety? How do they overcome the constant anxiety or that, that internal danger alarm going off in their head like crazy? And then art and music. For whatever reason, if I can ask my clients, what are you feeling? How do you feel? I don't know. Or I'm pissed. Well, what were you before you were pissed? I don't know. I'm just pissed. And so I integrate a lot of art and music. One of the reasons, especially for the art piece of it with our culture, we have medicine societies that used art exclusively, whether it was the Iroquois Society of Mystic Animals, the Midwin of the Ojibwe is a good example, the medicine societies of the Pueblo and the Dene. A lot of the ceremonies of those two cultures heavily have art elements. So there's that effective medium for expression of thoughts and feelings, especially when they struggle with words. Kids, adults, it doesn't matter. Draw it out, paint it out. Give them a big sheet of flip chart paper and some pastels or crayons or whatever you want to use, and just let them, whatever you're feeling, just put it on paper. Let me see what it looks like. Well, I'm not a good drawer. You don't have to draw. Just whatever you're feeling, put it on the paper. Just get it out of your head and out of your heart and onto this paper so we can look at what's going on. Those healing stories. So my kid that told his story through Panther, he actually did it in comic book format. So he wrote and drew a comic book to tell his story. Those illustrations, the sculpture, the beadwork. And one of the things I find is really interesting about our people, especially if you go to powwow, is that I can be a traditional dancer, a fancy dancer, either in the men's or women's category, and I can be part of the collective, and there's a set look of how the dance steps are supposed to be and how the dance style is supposed to look. But what I love is the level of individual expression that comes out in the regalia and the way the beadwork is designed and the way if you wear in bustles, how the feathers are tied for the women that carry the shawls, how the shawls are decorated. And so even being part of the collective and being out there as part of a collective in their category, there's freedom to have that individual expression of, this is me. And I think encouraging that through art and encouraging that through a lot of our traditional art, or even creating modern mediums for that, is very helpful for a lot of our clients, again, to get their story out and get their feelings out so that they're not all cooped up. And that helps calm the amygdala down so their brain's no longer, I'm in danger, I'm in danger, I'm in danger. I love integrating music. Again, for our people, we traditionally use music. We had healing songs, prayer songs. Of course, got the powwow songs, ceremonial songs. So it's there. And one of the things I do is for some of my clients, if they won't draw, if they won't, put something on paper for me, if it was a song, what would it sound like? And so for some of my kids and some of my adults, I might get traditional music. I might get a prayer song, with the drum, or I might get rap. I might get country. I might get, some army, whatever music they listen to. If it helps them express whatever they're feeling, and sometimes it might just be noise. But if it was a song, what would it feel like? And I think this is really helpful, and I'm going to use the Kiowa perspective as an example, because with the Kiowa, Da is their word for power. And then if for those of you who are Kiowa, if I'm mispronouncing this, I'm sorry. But you got Ki for throw, and then Ge for the catch. And so, God, Daki, and music, Dage, is the power, that root word of power is in there. So from their perspective, the essence of God is sent from God through music, and the drummers and the singers receive that power, and then they distribute it out. Therefore, music is power, and things like the gourd dance, especially. But a lot of those songs, from the Kiowa perspective, contain God's healing power. And so, for those of you who aren't Kiowa, whatever tribal tradition you have where music is concerned, it probably looks a little similar to this, simply because I don't know a single Native ceremony in my travels across this country where healing ceremonies or traditional ceremonies don't involve music. And so that chance to use music as a part of a healing tool to help them get to a healthier place, I find, has been extremely helpful in working with my clients. Big thing on this, you don't have to be Native. Everybody should know this. But I also believe that there's a stereotype that if you're not in recovery, you can't work well with this population, and I believe that is wrong. I think what we need to do is be culturally responsive and be culturally competent, because we can't be 100% competent, but we want to be as responsive as possible, and that requires that understanding of historic trauma. And the big piece of that is the ability to foster hope and celebrate those small victories, because what seems like a small victory to us is a huge victory for our clients. Any questions?
Hey, David, this is Jenny. I have a question somebody asked fairly early in the presentation, and her question was really at why or what are people attributing higher rates of drug and alcohol use to in this population?
So in the non-native world, the
And I'm
research
assuming,
that I'm finding, we've heard all kinds of arguments that we're genetically predisposed to alcoholism. I've heard arguments it's because we can't process sugar, because of lower insulin levels. I've heard one person state it's because American Indians lack the enzyme that gives the flush, so that, non-native people, when they've had 4 or 5 drinks, they start feeling this tingling in their face, and they know they're getting, they know they're close to having drank too much. And this person honestly believes that Indian people don't feel that, and that's why they just keep drinking until they pass out. I would attribute this, again, from just basically the work that I've done, and evidence is showing, especially the research in both non-native and native populations, is that for a good number of addicts, the root cause of the addiction is almost always an unresolved childhood trauma, and generally a trauma that occurred between the ages of 7 and 10. That's not always the case. I know one case, the addiction came as an adult because the addict that I was working with had actually been sexually assaulted by her father when she was 17. And so, but that was the root trauma. She never got counseling for it. She never got treatment for it. She had relatives say it's her fault because she was drinking with her dad, and you know how he is. And so that just, compounded the trauma. Add the history that some of our communities have of we don't talk about this kind of stuff. And yeah, the only way to deal with that anxiety and the trauma from that assault was to start drinking. So it's not always childhood trauma, but a good number of the clients that I've worked with, once I get back to that root trauma, then the world and the addiction starts making sense to the client, and then we can start speaking that language of change to help them get healthier. Hopefully that answered their question.
Thank you, David. This is Lena. We have a question from Karen. She says there have been some recent stories in the news about group or multiple suicides in a Native group. What are the causes?
Again, that cause would go back to, I would say, if we're looking at the attachment piece of it, if I don't have a healthy hippocampus that helps me create healthy attachment to another human being, I'm going to attach to other unhealthy people. And if my brain and my community of unhealthy people have never had success to overcome the tragedies, the trials, or whatever, then we're all going to be at a higher risk. And suicide tends to happen in clusters regardless of population. Good example would be here in Denver, in the Denver area. Douglas County, one of the most affluent counties in Colorado, also has one of the highest teen suicide rates, because once it started with one of the kids from that relatively well-off community, then other kids just kind of followed suit. And so with teen suicide, we have to be really careful that this can be a systemic thing in the community. If we don't, again, address those underlying soul wounds, to help get, and that's why I said I can't be an individual therapist and just work with the person. I've got to look at the community, I've got to look at the family, and I've got to be willing to work up and down, back and forth between all three roles at any given moment as a counselor.
Great, thank you so much. So we have one more question. In regards to self-differentiation, when clients need to return to family systems where other family members have not received treatment or see that is not beneficial, what are some coping tools or life strategies you suggest or teach, or for that person attempting to overcome trauma?
Yes. The big piece of that is the giving them permission to create boundaries. I think for a lot of Native people, because our definition of family is so broad, the Lakota are a good example. I mean, they have a word for people that are like relatives but not blood relatives. I mean, Toyashpeye, and I think for most of us, we have a version of that. But again, if we're drawing unhealthy people into that family system, what do I need to change in that system to create a better outcome for me and my children and my grandchildren if I'm a legacy thinker? And so, what do healthy boundaries look like? More importantly, how can I limit unhealthy exposure and still be part of the community, still be still be connected to the healthy people in the community? A good example would be a lot of my Lakota clients. I would always, kind of push them in the direction of Doug Goodfeather here in Denver at the Lakota Way Healing Center, so that, start doing sweat lodge and start, for those that, been sober long enough, let Doug help them get ready for Sundance so they can go do Sundance and experience that spiritual connection, be part of that spiritual community, and be away from that unhealthy community that tends to put them at risk for relapse. So I think it's every individual is going to be a little different, but I think the more we can do to help them find that sense of self, and then help them redefine what my new community and what my new family will look like when I'm healthy, is a big part of that. You don't have to give up your Native identity just because you're sober. Hopefully that answered the question.
Thank you so much, David. The last question is, where can we get additional training of this type?
So the trauma-focused cognitive behavior therapy, that training is at the University of Oklahoma. Dolores Bigfoot runs that program. You have to apply for that program. You'll go through the trauma-focused cognitive behavior therapy training. When you look at the criteria on the website, it says you have to have your master's and have to have that. They accept people that are providers in the community regardless of education level. And so you get the 2-day trauma-focused cognitive behavior therapy course, which goes into the brain trauma and the historic trauma model. But what I liked about that program then was the additional training, so even more time there in Oklahoma City, focused on cultural adaptation. And so how do we adapt this model for people from the Iroquois community? How do we adapt this for people from the Southeastern tribes? How does this look for people from the Plains community? And so I think it was fantastic training. I am glad I went, because it is the basis of pretty much all the work I do, not just with the kids that are in the child welfare system, but when I have to do the family therapy with their parents, because I already know if I've got a traumatized child, I am probably dealing with traumatized adults. And that training is at the Indian Country Child Trauma Center. They have a website. You can look it up.
Okay, well, thank you so much, David, for joining us for the webinar, and thank you everyone who participated in the webinar. It was so great to have you all here. Within the next 24 hours, you will receive an email from the National American Indian and Alaska Native ATTC, which will include a link to the recording of this webinar, a link to the survey in case you are unable to access it, handouts to the presentation, and a CEH request form. So we're going to close the webinar, and you'll be redirected to our survey. And that survey will let you know how many people attended will let us know how many people attended our webinar, how satisfied you are with the webinar, and how useful our webinars are to you. Coming up in June, we'll have a session on recovery-oriented systems of care led by our director, Annalena Skinstad, Sean Baer, and myself. For our Essential Substance Abuse Skills webinar series on May 18th, Lenny Hayes will present clinical evaluation treatment planning. Thank you for your time participating in the session today, and we hope you've enjoyed the presentation. We look forward to hearing your feedback. Thanks again.